Good afternoon and welcome to the KIrby. Those of you who aren't located here, we're here to celebrate the career of coming up to be Emeritus Professor Andrew Lloyd on the verge of his retirement after a stellar career as a clinician-scientist. So before we start, I'd like to just acknowledge the traditional owners of the land on which we meet, the Bidjigal people, and pay my respects to elders past, present, and emerging, and extend that respect to any Aboriginal or Torres Strait Islanders that are joining us today, either here at the KIrby or online. So, as I said, today we're here to celebrate the life and career of Andrew Lloyd, who has been a stellar clinician-scientist. His contributions to science predate his joining the KIrby, but he's been with the KIrby since around about 2015, 2016, where he's run VISP, the viral immunology systems program. And Andrew has made contributions across many fields around particularly viral infections, and particularly hepatitis C, from quite basic translational observations. Early on, Andrew worked on chemokine receptors, and Andrew and I are old enough to remember a time when we didn't even know that chemokines and chemokine receptors existed. So from quite basic studies in tissue, long before that was something that people did, through to understanding host pathogen interactions and the determinants of outcome of hepatitis C and how people managed to clear hepatitis C. And that was done in the context of both elegant laboratory science, but couched in the context of really well set up cohort studies that collected the correct clinical data and tabulated that correctly, and collected high quality biobanking. And that's really something that I think the KIrby in general does very well, and we need not to forget those skills. And then on top of that, science-led, laboratory science-led research, Andrew has also extended those observations to how to control diseases like hepatitis C in systems like the prisons, and has looked at ways of innovating in that challenging environment, about making sure that people in those systems have the access to diagnosis and the best treatment available. So a career that spanned the laboratory right through to implementation, so extraordinary contributions. On top of that, he's also been a leader in our understanding of fatigue syndromes, and particularly chronic fatigue. And one of my earliest interactions with, my first interactions with Andrew was reading a paper that has been oft quoted about the use of intravenous immunoglobulin for the treatment of chronic fatigue syndrome. But my first, I think, meeting with Andrew was when I was a PhD student at the Centre for Immunology, when we had what would now be called an RPR, but Ron Penny had set up these PhD review panels long before they were mandated by the university. And in those days, we didn't just review people's progress, we challenged the science. And I can tell you that Andrew challenged my science considerably. I think that was 1995, so I think many of you in the room probably weren't even born then. Certainly, we didn't know about chemokine receptors in 1995. Anyway, after I came back from Oxford, I was lucky enough to work on the immune-based therapies working group. And I worked with Andrew closely there. And one of the great things that came out of the immune-based therapies working group is now the IVRN, and particularly the quality control system around storing PBMCs and making sure that PBMCs are stored properly and in a viable fashion for effective biobanking. And I can assure you that that's something that's not done well around the world, and there's very few other quality control systems for that anywhere on the globe. And through Andrew's advocacy and leadership and the sustaining the IVRN with Tony Cunningham, we've managed to maintain that for well over 20 years. And so I won't keep going year by year, but there are some of my earliest interactions with Andrew. I'll hand over now to Nicodemus Tedla to talk a little bit about Andrew. And Nico, I found out through reading this, was Andrew's first PhD student.
I've never been as nervous in my life. But yeah, so good afternoon, everyone. I think thank you, Tony, for this fantastic introduction. This is probably one of the greatest honors that I ever had to talk about this amazing, distinguished career of Andrew. Sorry if I get emotional. So to start with, I was having a chat with Dennis Wakefield, who's the person that knew Andrew more than anyone else, which unfortunately can't be here today because he had some other commitments. So I asked, can you describe Andrew in one line? He said, you can never describe Andrew in one line. I'll give you 3 lines. So I said, okay, I'll draft it and you could tell me what it is. So I drafted this. In one line, I would say he's curious, inquisitive, rigorous, dedicated, humble, approachable, and an effective problem solver who never ate lunch, but lived in 1 apple a day. And then when I passed it to Dennis, he said he wholeheartedly agreed, except I forgot 1 word. And then he said he's also a multitasker. So I think that explains who Andrew is. I was given this an invaluable task. English is not my first language, I can understand that. To summarize Andrew's career in 10 minutes. So I tried, okay, let me ask ChatGPT to help me. So ChatGPT gave me a 60-page document. So I said, oh no, maybe I'll do my best to summarize it into maybe 3.5 pages. So I'm not going to keep you forever. I'm going to make it at 3.5 pages. So I'll try to be very succinct and without making it sound like an Oscar or Tony Award, and not intended, or worse, not another obituary. So I am trying to make it like a very happy celebration for someone who is never going to retire anyway. So as a research-focused practitioner, clinician, academic, and extraordinary mentor, Andrew had provided a distinguished service to the field of clinical infectious disease epidemiology and health services, as well as cutting-edge basic research. But this is for almost 40 years. But his contribution to hepatitis C and the chronic fatigue probably stand way above everything else. He's been associated with the NSW since 1990, and then he went to the NIH, dragging the family, I guess, and for 3 years on a fellowship, and came back here in 1993 as a conjoint appointment, as well as part of the Prince of Wales Hospital. And then they liked him so much that they tenured him to 1997, which is a great idea because I wouldn't have had a supervisor otherwise. So, I just, before we come to the KIrby in 2016, Andrew had a successful lab called MDTR in the School of Biomedical Sciences. In addition to doing some incredible basic research, in addition to a lot of other things that he did, he also was very instrumental in the merger that happened between the different schools into departments and getting lab spaces and research groups that now are almost established, and makes the School of Biomedical Science one of the best research precincts in the area at the NSW and beyond. So that, and while he's doing that, I said, if there's 24 hours in a day, Andrew probably works 48 hours in a day, because every hour is 2 times more efficient. So otherwise, in 2007, he created the NSW Fatigue Clinic, and this is quite integrated clinical services, research, and also other elements. So that includes continuously funded research protocol framework, and this overlaps with a lot of clinical work and patient service, but that actually led to expanding this into the so-called the Cancer Survivor Research Group, or what call, and then lately COFFEE, which is a nice acronym, so I'm trying to call it International Collaborative on Fatigue Following Infection. So definitely fatigue is, even though he never gets tired, he's interested in fatigue, which is kind of interesting. But this really attests that Andrew takes a very challenging topics, or sometimes topics that mostly affects underprivileged and overlooked communities like prisoners. And that actually shows you how deeply he cares for the clinical outcomes of everyone, regardless, and especially the ones that are overlooked. So that makes it really quite, and his research is always, like Tony said, is translational and applied. I mean, probably applied was what we used to use before translational research became applied in every word that we write now, but he was translational before translation was even named. And as a staff specialist in infectious disease at Prince Henry Hospital, he had a partnership with prison health services. He led the establishment of the hepatitis service in New South Wales prisons. And this really had the spin out to become nationally and internationally. And a lot of the things that he started and implemented is now actually widely used in the prison system. And also, this is when Andrew actually well-deservedly got the recognition through the Australian Medal in 2002, which is probably, if it was for me, I probably would have knighted him. But then if we knight Andrew, he would have become Sir Andrew Russell Lloyd, the Earl of Malabar. And I don't think that he would like that. So, but definitely his services well deserved that. And also, as an Earl of Malabar, Andrea would have to become a dame, or I don't think she would have liked that either. So, I don't think I can go through all the list, but as the national and international leader in hepatitis C prison sector through the Australian National Prison Hepatitis Network, and then he also established a quite broad, like in terms of the administrative part of it in the corrections, justice, health sector, as well as representing from jurisdictions and Commonwealth health policy, academia, consumer organizations, and for all states and territories. And this is not small feat. It's quite a lot of things that he does. And then his ongoing leadership on this arena has become highly influential in the organization, in the sector, providing knowledge exchange, advocacy, clinical practice, guidelines, facilitating Commonwealth-funded collaborative research, And also the international, this has expanded way in the international arena through the International Prison Hepatitis Network that does exactly the same thing in much, much bigger scale that I can't imagine. In relation to the fatigue, as I said, he still leads the post-infection fatigue syndrome or the COPI, especially including those SARS and CoV-2. And as a deputy director of the Commonwealth Fund Center for HIV and Hepatitis SCA4, which they will have their conference in tomorrow, he has done quite incredible amount of work and delivered tangible, practical, and things that changed careers of some, and also the welfare of his patients and consumers. Through, his contribution to NHMRC has been a long-standing, through advisory boards, through grant reviews, through policy changes and all. And his clinical work over 30 years is definitely highly impactful. And I don't need to tell you how many patients he saved or treated. I think that would look like a telephone directory, because ChatGPT gave me about 11 pages of it. So although he's always been research focused, he's also a passionate advocate of teaching, and also undergraduates, postgraduates, clinicians, the enormous number, which I will come to it a bit later. And I think having the research underpinning, the hands-on clinical practice, and the always approachable is always being appreciated by the students. I have stopped counting the number of honors students that we didn't list them because too many of them, but the number of PhD students way over 45, which for the first time in my life, I'm actually first. So that's very good. So, and I get that honor of being the first PhD, and I cannot thank Andrew more, which I will come back to it a little bit later. And that is more to my being a PhD supervisor. Andrew is also instrumental for getting the first Tedla, Australian-born Tedla in Australia, because my wife and myself were met in Andrew's lab. So he's also a perfect matchmaker. So for Andrew, there are now the population of Tedlas in Australia has increased by 75%. So it is pretty impressive. So that's very practical, I would say. Postgraduate teaching, I think the programs that established for the nurses that work in the prison system, a workforce that's required, and that's being implemented nationally and also probably getting taken up internationally, is quite groundbreaking, because specialized nursing in the prison system for the treatment of hepatitis was a non-existent. So that is quite impressive. I think the impact of Andrew's research, which is underpinned by health service innovation, which incorporates clinical practice, and which is already now taken up nationally and internationally, and it has a direct effect, a direct impact on the consumer, which is the patients, and the community at large. It's not, we all like our Nature paper, our Lancet paper, our New England paper. Fantastic, I think that's great. But when it impacts an individual patient, that is impact to me. Me and myself being from a background of trauma surgery, I can understand that one patient saved is one Nature paper, as much as which was concerned, or paid more. But okay, I will go to the metrics. Right? Why not? So it had an impressive 452 publications, over 20,000 citations, and H-index of 78. It's like mind-boggling. I don't want to see to my impact factors, That's why I don't like metrics. And the fieldwide citation index of 4.41, which is way, way higher than I could ever imagine. And he had amassed a whopping $125 million income, 7.9 million just in the last 5 or 6 years. I mean, this is, for me, that came from one of the poorest countries in the world. That is actually the GDP of my country. But it is money well spent. It's absolutely amazing. And for me personally, the standout is Andrew is an outstanding multi-award winning supervisor, mentor, and an amazing colleague. He had over 45 HDR students from over 15 countries with different backgrounds, different needs, different culture, different everything, and he could accommodate us all. I'm pretty sure when you read my Eritrean English or Hindi English or Urdu English or Japanese English or Chinese English, must have been very challenging, but I've never heard him say, this is crap. There is a room for improvement. So I think that shows you how patient he was with us and how he actually allowed us to try. And I reckon he should have started a language institute. You would have made a fantastic side hustle and become a millionaire. But I think he has been instrumental in making the successful career of a lot of us. Some of them was pretty rare. But for me, and another standout is Andrew has planned the succession plan. I like to, a lot of us as academics, we don't prepare ourselves for a very smooth transition to the future. That will have a lot of ramifications because the continuity of research doesn't start and finish in one generation, it's intergenerational. So I actually am incredibly in awe with Andrew for this amazing transition that's going through on, like Rowena taking on the laboratory immunovirology, Bezad and Yumi taking on the clinical and molecular research, and Carolina getting here the fatigue research area. I think that is a testament to say that he's selfless, he's happy to give it up, he's not going to go to the grave. That's not opportunity. So at a personal level, I'm almost there. At a very personal level, when I came to Australia in 1993, I knew nothing. In fact, it took about 72 hours to come here. So I thought I'm going to I'm going to use our good language to the ass end of the planet, because it took me 7 days because I bought the cheapest ticket because I couldn't afford it. So when I arrived to Australia, it felt I was in a different planet. But first, the people that I started working, a lot of the PhD student honors and research assistants, everything, were incredibly helpful. One thing that I didn't realize is when I just went from, I was studying in East Germany, orthopedic surgery, so I moved to Australia, instead of going back to Ethiopia, then part of Eritrea and Ethiopia were in civil war, and joined the army. I absconded and wrote many applications and got accepted to come to Australia. I got a scholarship, and in that scholarship was only to pay my tuition fee. I didn't realize that I didn't have any living allowance, and I only had like $30 in my pocket. So the shock was, I can't go back. I'm stuck here. What do I do now? But the people like Andrew and then John Dwyer and Reg Lampotang all rallied around, and they created a scholarship for me. In return, I will have never to leave the lab. So I mean, to make that instantly shows the human part of it, that I'm enormously grateful. But then came me being an orthopedic surgeon, never being in a lab, never knew how to be pet, didn't know anything. I struggled for the first 18 months and didn't know how to pet, as I said. And then here comes Andrew, rescues my PhD. At the end of it, 4 publications, the fellowship to go to Harvard, and the rest is history. I've also told you he was a fantastic matchmaker. For me, the single most important thing is my family. Well, there are only 4 Tedlas in Australia, or 3. Pauline didn't take and Pauline is the second PhD student. I'm hoping that she will come here and she tells her own story. But one thing that I truly, truly appreciated about Andrew was patience. He was very patient with all the things that I have to learn from scratch. And that one day I was working late with animals and things like that. And he said, you will wait and give me a lift. I used to live at Prince Henry Hospital. And I kept him waiting. And it was nearly like 7 o'clock. So I'm going to apologize today to Iva. I think you must have been in either Bridgeton or St. Clair, I didn't know, one of the schools, playing guitar. So we kept you waiting. So today is my redemption day. I'm going to apologize that you've been absolute, I don't know, I'm out of words. So thank you, Andrew. Thank you for creating an environment that allowed us to thrive. You are leaving an amazing and lasting legacy through your groundbreaking research, your extensive service to the community, and through the many, many, many generations of scientists, clinicians you've trained. And I am going to say, even though this is supposed to be a retirement, I checked your calendar today. And in the calendar, it says, Andrew is going to have 2 jointly supervised PhD students, 2 co-supervised PhD students, mentoring several careers, still a large-scale funded MRF grants, one of them shared with Tony, I think. The H3SQ, sometimes I have to memorize the abbreviations, MRFs, viral genomic thing. There is upraise thing, there's ACH4, there's coffee, there is tea, there is sandwich, a lot of things that is going to keep going. So finally, and most importantly, on behalf of all of us that benefited from Andrew, I would like to thank you, or maybe apologize, to Andrea, Iva, Beck, Simon, David, and your family for keeping Andrew endless hours during the weekend. By the way, either Simon or David once, when I was talking to Andrew, he must have been 6, 7, or 8-year-old, told Andrew while we were meeting, and now that I'm a parent myself, I felt bad today. At that time I didn't, but I think you must have asked him to come. And Andrew was saying, yeah, I will. But so I think, thank you. Plus, Andrea and the family for opening your house and for welcoming us through the many, many, many Christmas parties and get-togethers, and especially for those of us who were far away from our loved ones and families. You were our family, and I at least personally am perpetually grateful. Thank you, everyone.
Thanks very much, Tony and Nico. And please, I'm going to try and reduce some of the hyperbole that you heard. I do want to acknowledge all the people who have gathered here today to celebrate my retirement, and also all those online. I wanted, to be honest, it's great to welcome so many colleagues and friends from all of my interactions in the hospitals, in the prisons, in the university, in many locations. And like Nico flagged, I did particularly want to thank my wife, Andrea, who's sitting in the third row on the right there, and my 4 kids, that's Eva, Rebecca, Simon, and David, that Nico alluded to, and actually their families, and that includes the 7 grandkids, still counting in that regard. What I plan to do in my brief talk is to just give you some selected reflections and maybe a few anecdotes from about 40 years of life and work as a clinician researcher. And my goal in doing that is to offer some insights to the opportunities that I've had and maybe some lessons learned. You know, I do remember having attended other retirement speeches, and I think, especially if it's somebody you really might admire, you'd like to take away the pearls of wisdom. What are the things that I might take into my own circumstance and learn from, even if not necessarily having to go through the same experience. So I've got 5 or 6 stories to tell you that mark that journey that Nico's described for you. And so you might have to just bear with me a little bit to manage those stories. And my apologies if any of them you've heard already. I do have a good repertoire, but so to start the ball rolling, it is quite an interesting experience as a clinician and researcher, looking back to think about how you get to this spot. And I have to say that my journey as a clinician, or my journey as a clinician researcher, but it started as a clinician. And to be honest, that started because when I grew up, I lived a lot of my childhood in New Guinea, that's in Papua New Guinea. And in that context, somewhere along the way, I learned that I had a bit of brain power, so I was not too bad at school. And so I thought, well, I could become a doctor. This could be neat. And I looked all around me, and there was lots of infectious diseases widely apparent. I thought, okay, infectious diseases could be my thing. This is when I was in primary school, I had to tell you. In looking back, it's a little bit weird, but I did think that working in an area where you can do good for people, like Nico was alluding to, looking after the health of people and hopefully curing them and getting them better, which is supposed to be the mantra for infectious disease, that sounded like a great gig. And so I thought, okay, this is it. And when I was a medical student, Andrea and I went to New Guinea for a medical elective term. And one of the very first patients I was given responsibility for, again, in retrospect, it sounds a little bit dangerous. I was just an ignorant medical student. But anyway, we're in a little place called Wewak up on the far north coast of Papua New Guinea, where services were pretty limited. And I remember one of the very first patients I got to look after was a young woman, a young Papuan woman, who had spent maybe like a day, I think it was, traveling with her father down from one of the remote villages along the coastline. And when she arrived, I remember that we were called to come and help carry her out of what they call a PMV, which is like a public motor vehicle. It's like a ute with a cover on it. So she was in the back of the ute and unconscious, maybe 12 or 13 years old, and really seriously unwell. And I had enough medical knowledge at that time to realize this is not good. And the father of this young teenager, you can understand, was extremely distraught. And so anyway, we didn't have much in the way of laboratory capacity in this little hospital up in Wewak. And so what we were able to work out was that she was very febrile. She didn't actually have any neck stiffness, but she was deeply unconscious. And we were able to do, it's a do-it-yourself job, but we were able to take some blood and look for malaria parasites, and worked out that she had lots of malaria parasites in her blood. So, okay, this is kind of 1 + 1 = 2. So she had cerebral malaria. And there were only very limited repertoire of therapeutics available. So that was really chloramphenicol for antibiotics, and chloroquine if the person was well enough to take a tablet, otherwise quinine by intravenous infusion. And so we gave this young lady quinine by intravenous infusion. And I remember going home after looking after her during the day and thought, she's definitely going to die overnight. It's going to be a bad story. And the father really had already resigned himself to that bad outcome. And when I arrived the next morning, it was actually something close to a miracle, because she got better. She woke up and she started to talk, and it was really just a dramatic outcome. And so that experience really cemented for me what I thought might be good to do as a career, which was infectious diseases clinical practice. And that great opportunity to do good for the individual is extremely satisfying. And so that I thought, this is it. I'm on my road for infectious diseases. Wasn't too many years later that actually, so that was in the late 1980s, that was in the late 1980s that I was in New Guinea, or we were in New Guinea. By the time I became established in my infectious diseases training, which was in the early 1980s, the HIV epidemic struck. And so one of my main jobs, I was based at Prince Henry, Prince of Wales. Prince Henry's now gone, but Prince of Wales is still present. And there was a big HIV unit, both at St Vincent's, but also at Prince Henry, Prince of Wales. And so one of my main job was to look after all the patients with HIV infection. And you can picture the circumstance. This is prior to antiretrovirals, at a time when we really actually didn't understand very well, or we're still worried about how HIV was transmitted. And patients were there was a relatively famous, or maybe infamous, politician called Fred Nile, who's one of early comments in the context of the HIV epidemic, which in Australia, like everywhere else, was largely affecting young gay men. He suggested they put them all out at La Perouse. That was because that was a tradition of, that's where the leprosy colony was. That was where people went to die with anthrax and other incurable illnesses over the previous century. He suggested we put them all out there and we'll build a wall across the peninsula and we'll keep them all out there. It's just memorable statement. Anyway, during this couple of years, I was working as the infectious diseases registrar. I'm not sure exactly, but I looked after of the order of 100 young men who were sort of the same age as I was at that time, essentially all of whom died. And I learned from that infectious disease is not only about wonder drugs and cure, but about providing relief in very difficult circumstances. So I learned the benefits of doing that, and learning that other goals and priorities can become important in clinical care, to relieve suffering and so on. I do remember one of the very first, as an insight to this era, one of the very first patients I looked after was a young, it might have been like a 20-year-old gay man who was of Catholic Maltese background. And this young man unfortunately presented with very late stage HIV, so he's seriously unwell when he arrived. And he disclosed to us that he hadn't told his parents with whom he was living that he had HIV, hadn't told them that he was gay, hadn't told them that he was living with HIV infection, and hadn't told them that he was seriously unwell. And over the 6 or 12 months I looked after him until he died, he was determined that no one could know, because he was too traumatized by the thought that his conservative Catholic parents would disown him and that he'd be out on the street, and that all the nurses and doctors in the hospital had to maintain that confidentiality that he imposed on us, which we fortunately did pretty well. But it was a very emotional period of time in my life, and obviously for all the young men that I looked after at that time. I wanted to segue now just to tell you a bit of another story about sort of moving on from clinical work, which I found very satisfying. But I must say I did, after the end of my infectious diseases training, I pretty quickly worked out that this sounds a bit bad, but I did quickly work out that after about 30 seconds of the patient talking, you could more or less work out what the diagnosis was. And instantaneously, I thought, okay, this is strep throat or this is something else, and we just need to give this antibiotic and that's it, it'll be sweet. I thought, oh, okay, that's not terribly intellectually demanding. I'm being a bit dismissive. There were some tougher cases, you know, like on House or whatever, but you know, there were a few tougher cases. But that led to me to think that I really needed to get, I had dabbled a bit in research, but I needed to get a bit more serious on the research front. And to some extent, the rest of my research career was shaped a little bit by the serendipity or the circumstance of two patients consecutively that came to the outpatient infectious diseases clinic. The first of them was a young lady whose name was Sharon, who was a university student. I think she was studying science, or can't remember what she was studying, working hard, pretty happy, healthy, exercising and so on. And she got quite nasty glandular fever. And she was crook for a week or two with fevers, sore throat, tender lymph nodes. Not bad enough to be in hospital or anything like that, just walking wounded. And then she came to us because 2 or 3 months down the track, she was wondering, everybody else was wondering why she wasn't better. And when we asked her about what is it that's making you unable to be back and get into your study, she said, I'm tired all the time, I'm fatigued. And what she really meant was a combination of being physically worn out, even though there wasn't anything wrong with her muscles, and cognitively worn out. She couldn't concentrate to do her study. She was good for 10 minutes, but after that, her brain would go to mush, so to speak. And then next patient in line was another really nice young guy named Keith, who was actually a foreman, a similar age, maybe 25 or so, from Condobolin in Western New South Wales. He was a foreman in the abattoir. And he told me the story how he'd come home from work in the abattoir and he just very abruptly became unwell, like severely unwell, with high fevers. And he said he had these headaches that were affecting the back of his eyes, and he had drenching sweats. And he was very embarrassed by the fact that he got into the shower to rinse off all the drenching sweat, and his mum had to pull him out of the shower because he couldn't stand any longer. So he had what we now know to be acute Q fever. And he was appropriately diagnosed and treated, but same kind of story. 2 or 3 months down the track, he was struggling to be at work for more than an hour or two. And his main complaint was fatigue. Q fever is a bit of a complicated illness. It's a bacterial infection, and it sometimes can cause persisting, replicating pathogen, bacterial pathogen, replicating in the heart or in the liver or in the bones. So we checked out to make sure he didn't have any of that. And his fatigue, which was profound, was really unexplained. And it was very like what the other young lady was describing. I thought, oh, okay. So I had to talk to my bosses at that time, including Dennis Wakefield, and said, look, I'm thinking of doing some research. And I'm wondering about this as a topic. There's this post-infective fatigue thing. And they said, great idea. This is a great topic. And to cut a long story short, they said to me, Andrew, this is a perfect PhD. No one understands this bloody thing. It's hardly studied at all. It's much maligned. There's really only going to be 2 possibilities, and you'll be able to sort it out 3 years or less. It's going to be A or B. It's either going to be the bug persists, or it's going to be the way the body's immune response, which responds to the bug to control the infection, that persists. Maybe the bug's gone, but the inflammation, the immunity is persisting. And so 3 years later, after I'd done a whole heap of studies, what I found out it was neither A nor B, actually. In fact, it wasn't even C, D, E, or F. so we worked out it wasn't a psychiatric disorder, and it wasn't a hormonal disorder, and it wasn't a muscle disorder. So we really worked out a lot about what it was not. And perhaps sadly, I'm not sure, that really set me on a lifelong journey in the research sense of being interested in fatigue, which Carolina might mention again. And that's culminated again with a total sense of deja vu in long COVID, which is really just another post-viral fatigue syndrome and is equally enigmatic now as it was back then. Okay, now the next life lesson I learned, was that my bosses after my PhD said to me, Andrew, okay, you've done a great job, it was quite a productive PhD. You really need to move on from this somewhat stigmatized, poorly understood condition and do some real science. I think those words were used. And so one of my bosses organized me to go to a molecular biology lab. This is like real science at the NIH in the United States. And so I dragged my young family to the United States, and I moved to this lab, which was interested in this family of molecules, I think that Tony alluded to, chemokines, so chemoattractant cytokines. And this lab was discovering the chemokines, these proteins, of which there's quite a large family, and also the receptors, the thing on the surface of cells for which they bind. And so we were cloning chemokines and chemokine receptors. Now, for those of you who work in the wet laboratory, you may not realize, but there was a time before the machines really just did everything. So this was prior to the sequencing of the genome. So cloning was a challenging task. One of the aspects of that was that sequencing, for instance, it involved pouring large, this sort of large 3 to 4 millimeter thick, wafer thin polyacrylamide gels on 2 great big large plates. One you had to make sticky, one you had to make non-sticky. Pour these gels, run the samples on these gels, and this sounds crazy to think about it because it's so techy now, but each nucleotide, there are 4 nucleotides in the genome. Each nucleotide had to run on one individual lane, and you could get about, Tony's nodding, you could get about 400 nucleotides worth of length of read if you're doing really well. And the process involved radioactive isotopes, so P32, which was labeled to help identify the sequence. And you had to manually get this big gel onto a piece of paper and then onto an X-ray film, and then you had to develop the films. It's quite a manual process, as you can imagine. Got some dangers associated with it. Anyway, it was a great experience, and we cloned some genes. It was all very successful. One of the first things that I remember from working in that lab, though, is that it was the first time I'd worked in a real scientist's lab. So everybody else in the lab, apart from me, was like a serious researcher, and they were all postdoctoral scientists, 3 or 4 years postdoc, and had all been doing basic science, mostly molecular biology, since day dot. And so they had a lot of prior knowledge, which I definitely didn't have. And one of the very first memorable experiences was that my boss in the lab asked me to work out the molar ratio of 2 substances that I was using. And so for those of you who don't do wet laboratory research, that requires a key element, which is Avogadro's number. And Avogadro's number it links the molecular weight of a substance of any sort to the number of grams that you use to make a specified amount. So if you want to have 2 substances in an equal molar ratio, you have to use Avogadro's number. And so they said to me, Andrew, just calculate it, get the molecular weight, apply Avogadro's number, and work it out. And I said, what in the hell is Avogadro's number? And they were fortunately generous enough to train me up a little bit. Okay, moving on, we're getting close to the end. When I came back to Australia, or perhaps I would say one of the lessons I learned from that experience, so going from clinically oriented research to molecular biology. When I came back to Australia to continue my research, I really felt as though there shouldn't be any boundaries about what I should take on. It's a dangerous thought, actually. You know, so I felt completely happy to embrace new disciplines, new techniques, new technologies. And that I do think, not everybody would like this idea, but I do think it's an attribute that can stand you in good stead to face the challenge of whatever it is. Don't feel as though you can't move outside your traditional boundary. When I came back to Australia, I early on in the piece, I had been doing HIV clinics in the prison because there's a lot of concern about, that's the infectious diseases type clinics in the prison, because there was a lot of anxiety about HIV outbreaks in the prison, which had happened in other countries overseas. Unfortunately, here in Australia, we never really got much of an outbreak amongst people who inject drugs, and so who are well represented in the prisons. And so HIV was relatively a non-issue. And so early in the piece of that era when I first came back, we rapidly realized that there was this new virus, hepatitis C, traditionally known as non-A, non-B. And in contrast to HIV, where there was hardly anybody affected in the prisons, there were lots of people affected by hepatitis C in the prisons. And so that led me to jump ship a little bit and just take up the reins on the hepatitis C front, both in clinical care and in research. And so 2 more stories. One story is early on in the piece of providing clinical services for hepatitis C in the prisons. One of the things I was keen to do was to take the healthcare to the patient kind of thing. Whereas traditionally patients would have to come outside of the prison, escorted by 2 correctional officers, taken in green uniforms and shackles into the hospital outpatient clinic. And to be honest, no one was really happy about that. The prisoner wasn't very happy. The healthcare staff in the prison felt a bit disenfranchised. The corrective services didn't like to have to commit 2 corrective services officers to escort a patient to the hospital. And so I said, we should bring the service into the prisons. And at that time, to actually get hepatitis C treatment, which wasn't great really, to be honest, but it had some cure, it required a liver biopsy. And so I said, okay, we'll start. I'd been doing liver biopsies on the ground in Papua New Guinea, so I thought this should, not too big a deal. We'll be able to do liver biopsies in the prison. And so we started doing liver biopsies in the prison. And one of my early experiences in doing this is that I had, I think, 2 or 3 patients lined up to have a liver biopsy, and they'd been put into a room, like an outpatient clinic style room inside the prison. And there was 2 of them side by side with a sort of a curtain in between them so they could kind of hear what was happening next door. And to do a liver biopsy, in broad terms, you just get the patient to take a big breath, hold it in, stick a big needle into the liver in the side, about 10 centimeters long, and suck on a syringe and pull it out, and a very fine slither of the liver comes out. And that was a prerequisite to work out how much scarring there was to warrant it, to see if costly treatment was warranted. So anyway, one of these guys that I was looking after, who was in this pair that were lined up to have a liver biopsy, was this great big burly, tattooed, bodybuilding person in prison, and who had hepatitis C. And the other was a more slim and trim guy. And the big burly guy, sort of paradoxically, was reasonably health aware. So he's quite worried about his hepatitis C. And like I said, he was quite big in body build. And he was a pretty tough nut, to be honest. Anyway, so I did him first. I did the liver biopsy in him first. Went through the procedure, put the needle in and so on, and got a liver biopsy sample. And as soon as I was finished, he said, "Oh my God, that was nothing. Nowhere near as bad as being stabbed." And so after that, the word spread amongst the whole prison community, literally. "Now the liver biopsy is nothing. Don't worry, you'll be right. Go ahead, have treatments. Good as gold." Okay, my last story moves forward a little bit of a decade or so to the beginning of good antiviral therapies for hepatitis C. And so I vividly remember this is around 2016. So it's just at the time that the World Health Organization had announced that we wanted to try and eliminate hepatitis C as a public health threat globally. And so I was with a colleague of mine, Greg Dorr, who leads the viral hepatitis program here in the KIrby, and we were driving together to a meeting in rural Victoria, actually. And we said, oh, look, we should get serious. We were brainstorming a little bit about research projects. So we should get serious about trying to manage the contribution of the prisons to the elimination effort. And if we don't, we're going to find that there's just ongoing transmissions of hepatitis C in the prisons, and we definitely need to get serious about it. And so we brainstormed a bit, and then we, between us, came up with the idea, which actually wasn't completely novel because it had already been done a bit in HIV, and that's this idea of treatment as prevention. The idea being that if you treat the whole of an infected population, there'll be nobody left to transmit to the uninfected population. And that works in the prison in the hepatitis C context, in that there's about, at that time, there were about 20%, 1 in 5 persons had chronic hepatitis C, and all the rest didn't have chronic hepatitis C, but many of them were injecting drugs and transmitting to each other. So he said, okay, no worries. We will just treat everybody in the prison. Or no, we'll just test everybody in the prison, treat everybody who's infected, and that way we'll show that the incidence, the transmission rate, will drop. Bold idea. Especially given the logistics of the prison. The prisons are a very challenging environment. It's very rigid in a physical sense, intimidating, challenging organizationally. There's a health service, there's a corrections service, challenging patient population, lots of barriers. And anyway, we lobbied for a couple of years to get some support for this project, and then ran a 5-year project where we did exactly that in 4 prisons in New South Wales. And to do so, the one story I wanted to tell you was just that one of the interesting facilitators. You might think, oh no, delivering, especially public health research, you've just got to get in there and you work out what you're going to do and then just deliver it, kind of thing. But what we found in this Stop C study, it was called, was that there were some great facilitators of success. And one of the most notable of these is that one of the 4 prisons had a governor, that's a general manager, like a corrective services boss. So we were lucky enough to have some support from corrective services, in particular from Luke, who's in the audience, to tell the organisation, or to have the organisation on side with the project. But we met this governor, and he was on the money straight up. He said, oh, I get this. You're going to treat everybody and you'll reduce the number of infections that are occurring. And straight away he said, I reckon that's going to make it safer for all of the corrective services officers. I get it. This is a good idea. And so he then went on to sell exactly that story to all of his correctional staff. And the project was just a dream in that particular prison in particular, for the duration of the study. And over the course of that study, we enrolled everybody in the prison, or about 2/3 of all prisoners, tested them all, treated all the ones who were infected, and dropped the transmission rate by half. Okay, I'm going to finish now. So I think you might have gathered that I do feel uniquely fortunate to have had a very long and satisfying career in that clinician research mode, and to have made many friends and colleagues along the way, many of whom are here today. I have to say, I'm very grateful. I'm extremely grateful, to be honest, to my family, and that's to my wife, Andrea, who's an amazing and multi-talented woman, and to our 4 kids, who are all wonderful individuals in their own right. 2 of them have, under no influence of mine, become health professionals, and 2 of them have become academics in a completely different discipline, fortunately. They have endured my unequivocally long hours, and they've traipsed with me and Andrea to Papua New Guinea, to Saudi Arabia, to the USA. But I'm very proud to say that all four of them have acquired a very strong sense of social justice in everything that they do, which is something I would espouse. They've chosen great partners, and so far, like I was mentioning earlier on, they have generated 7 grandkids, and I think there's number 8 on the way. So we're very proud for the burgeoning clan. And so thank you again to all of them. And then my very last word of thank you is to thank Yumi, Rowena, Carolina, and Claire, and several folks from the KIrby who assisted in organising this event today. So thank you for the opportunity.
Thanks, Andrew, for those insights. And I think the part that he's probably underplayed in that is his leadership throughout that and his great ability to communicate as part of that leadership. So now we're going to hear some reflections from Carolina, Yumi, and Rowena, who are 3 of Andrew's long-standing mentees who are continuing his work across the 3 pillars: fatigue, prisons, and the lab, to share some of their experiences and stories with their time with Andrew. So we'll start with Carolina Sandler, who's a senior lecturer and co-director of the UNSW Fatigue Clinic and the Fatigue Research Program, and she'll be followed by Yumi Sheehan, who's a senior research fellow, and she leads the VIS Prism-based research program, and then by Rowena Bull, who's the group leader of the laboratory program. So over to you, Carolina. There you go.
So I'd first like to thank Andrew for talking today. We did have to coerce him into this whole event. But I personally find it really actually quite valuable to hear, a lot of our mentors talk about their careers. I was born in 1981, a pretty big year in virology. I remember a lot of the ad campaigns that are now ridiculed for HIV. I just knew there was a grim reaper out there that was going to take me out. I wasn't quite sure why. And so I think to hear about how particular their generation has really transformed that landscape in infectious diseases to how we have now, to really understand, I think, their personal stories about stigmatization and everything else that existed then, that, it's not perfect, but it's still really made a big difference. And I think it's really valuable, and it's always especially important for the honours and the young PhD students to realise how lucky they are that they've got the Ramaswamy Genomics Centre now, that they can just walk down and hand over a tube and don't have to run gel. So I always appreciate any story like that to, make them feel lucky. So I think we've heard a lot from Nico really about just how amazing Andrew's achievements were. And so I guess, how can we possibly replace Andrew? Well, I've done the maths and I've worked out there's going to be 9 of us really required to carry on what Andrew has been doing. So a real testimony, I think, to his achievements. We have Carolina, which we continue with the fatigue clinic. We've got Lucette with long COVID. We have Yumi and Bezad with the prisons cohort. We have Sarah Sasson, who's really going to be taking the National Biobank for IVRN forward. Nico and I, with the lab work and also the undergraduate teaching. And then also on top of all of that, there's the clinical roles that he had as well. And so I think between all of us, we'll bumble along and probably achieve half the success that he could manage to do on a day-to-day basis. So it's really quite a testimony. I joined Andrew back in 2010 as a young early career researcher. I was applying for what is, equivalent to now the NHMRC EL1 award, and they brought in this rule that you couldn't apply for the same field as what you did your PhD in. And I'd had my application to sort of try and work in the same field. I thought I'd sneak it in, knocked back at the 11th hour. And so I sort of knew Andrew and just thought, hey, Andrew, do you want to support my application that I think's due in 48 hours? And Andrew, being Andrew, said, sure, why not? And not only did he say, I'll put my name on your application, I think he actually spent a good amount of time leading up to that helping me write an application on hepatitis C, which I didn't know a lot about at the time. So I think that was probably the best rash decision I have ever made. So thank you, Andrew. You've definitely, I think, had the most significant impact on my career, and I very much feel like I've been able to ride your coattails, particularly with all your cohorts, and, you know, gain a lot of success from the work that you have done. So for those that are mentored by Andrew, you definitely know that he's never too busy for us. In fact, I think the more junior you are, then the more time Andrew has for you. And I think that's a pretty rare trait in a profession that's incredibly hierarchical. But then I think anyone that really knows Andrew knows that he definitely has a healthy thread of anarchy in his blood. So I think, you know, that definitely worked to our advantage. I'd like to thank Andrew for all the time that you've taken in helping me out, in particular providing a lot of the constructive, critical feedback. I've sort of come to a point now where I like to give things the Andrew test. So I'd knock on his door, usually, you know, unscheduled, and he'd never say no, even though I know he had a million things to do. I'd pitch my idea. I'm ready for it. He'd rip it to shreds, you know, both the scientific and the clinical relevance. And I'm like, great, this is what I need. And then I'd go away and I'd work out, all right, is it a bad idea? Do I just drop it, or do I problem solve it? Usually I'd problem solve it for a while. A few weeks would go, I'd go back to Andrew. By then he'd usually forgotten that I'd pitched the idea. I'd re-pitch my idea. And if it flew, then I went, yes. And Andrew would go, you know what, that's actually a pretty good idea. And I'm like, yes, all right, that one we're taking forward. So thank you for that. I think that one of the major contributions you've really had, particularly to our group, that is quite rare, just the breadth of the knowledge that you have is unparalleled. You know, immunology, virology, pathology, clinical medicine. And I think what you've really taught me, and I think just our group generally as a whole, is how to look at the project from multiple angles. As scientists, you know, we get very trapped in what our little pipette dishes, like what the results suggest, and we don't really think about what does that mean, or how do we think about that in the broader context. And I think that really relates back to, I think, you know, your clinician-scientist expertise. And I think, unfortunately, you know, we're probably seeing a bit of a decline in a lot of true clinician scientists. And I think that's really going to be a loss of the field of medical research. And so I think, you know, hopefully we can continue to keep that strength up. I'm especially grateful for the countless hours that you've spent reading my grants and papers, sometimes on a Sunday as well. So thank you, family, for when we've stolen him away for that. And I know it was not uncommon for me to have other collaborators or other people comment on just, I can't believe Andrew responded so quickly and gave such detailed feedback on my paper. So I know it's really been appreciated even outside our field or outside our group as well. I don't know whether I'm thanking you or apologizing for the very early chaotic days of COVID, when I was determined that I was going to establish my first clinical cohort. I think it was January 2020. I rocked up and said, I think this is going to be bad. I want to set up a cohort. And you said, you know nothing about clinical cohorts. And I went, I know, but it can't be that hard. So I guess I'd like to thank you, and also Marianne as well. I think you pulled me out of a few political holes that I fell down. But anyway, we got there in the end, set up a cohort that I think was reasonably successful. So thank you very much for that. I'm sure you had moments of thinking of me as a muddle-headed wombat, because I know that's often the phrase you like to use. So thank you. And I think I'd also like to thank you personally as well. The influence you've had on my life, whether it's giving me advice for my sick kids, you know, do I worry about them? Do I really have to take them to a hospital or not? And I think also particularly one of my stories was I'd been working with Andrew for about 2 years. I was about 8 months pregnant. And it's my first time I was pregnant, and I knocked on his door, and Andrew having a chat, and he said, so what are you going to actually do when you go on maternity leave? You organise who's going to take over your projects and everything else. I'm like, what are you talking about? I'll just keep working away. And she's like, oh, I don't know, it's a bit tricky, you know, they're a bit demanding. I'm like, oh, they just sleep. Babies just sleep all the time. I'll be right. I'll just keep doing this work, no problem at all. And he sort of looked at me a bit sort of, I don't know if you're sort of feeling sorry for me or... And just said, you know, there's this like whole mother-baby bonding thing. And I said, oh, I'm not going to be one of them. Like, anyway, thank you for not holding me to anything that I promised to do in those first 6 months. I was completely jinxed with a baby that didn't sleep for 9 months. So thank you very much for that. But I think finally, I think the most important thing that I'm really taking away from you is the example of how you've been such a compassionate mentor. And I think, yeah, this is the most important lesson really I've had. In a field that's becoming increasingly competitive, I think it is hard for the mentors with their students to really make sure we give them the time to be able to learn in their own time, learn in their own right, and be able to grow their strengths. And yeah, so I think from you, I've really learned that if we can give people the time and the support they need, they will get there and they can thrive. And so thank you very much. I think it's the most important lesson that I've learned, and I hope that's something that I can continue to emulate too with my own mentorship in that area. And I think one of the greatest testimonies, I think, really to your incredible career is the fact that a lot of those people that you've mentored, you've maintained long-term professional relationships and personal relationships with them as well. So I think that really is the greatest testimony to your output. So thank you.
Okay. I have my tissues. I'm ready. As soon as Nico started, it was over. I was disaster for me. Okay. Oh no, already. Oh dear. I promise I'm not distressed. I'm just very emotional. Okay, get it together. So I think, yeah, I did practice without crying many times, I promise. Okay. I think just looking around the room and seeing how diverse this whole group is, you can see the whole broad scope that Andrew has in his research and the impact, clearly, that he has on people. The fact there are so many of us that have to replace him, one of him, so many of us, I think just gives you an idea of how hard of a worker he is and how diverse his research program is. I think it's hard to go past the fact that all that hard work and generosity is that he shows us must come at some kind of cost or sacrifice to him, and I imagine his family. So I wanted to thank particularly Andrea for her support, especially to the fatigue clinic. Thank you for helping us how to figure out how to triage patients, how to set up the fatigue clinic admin, and even putting beautiful flowers on our desk, which is lovely. And particularly thank you to Andrea for being so patient when I and we as a collective have been so demanding on Andrew's time that he's so generously provided us. And me personally, I'd like to thank both Andrew and Andrew for providing some very helpful life advice, whether it's about having children or gallbladder surgery. It's always been very handy for me. So thank you very much. So I first met Andrew 17 years ago. In 2008, when I was a fourth year undergraduate exercise physiology student. Somehow he thought it was a good idea to give me this opportunity to do some admin work to help set up the fatigue clinic. Excuse me. So this brave man gave this completely clueless exercise physiologist with about half a brain the chance to be employed as a research assistant and as a clinician, and then as a PhD student, and then as a postdoc. So during our times together, Andrew has shared some pearls of wisdom, as he said, and I'd like to share some of those with you today. So one of the first things he said to me during my PhD was, when I started actually, he said, you know, PhD is not hard, it's just hard work. Just got to do hard work. And I think that was an important start to the mentor-mentee relationship, because it made me feel like actually anything was possible as long as you were willing to put in the hard yards. And then the advice turned a little bit more pragmatic. So for example, he'd say, okay, only action different ideas or concepts once I've mentioned them at least 3 times. Because with any luck, I'll forget about it. And then you won't have gone on like a wild goose chase. And I think maybe you might have learnt that your time during your PhD with Dennis Wakefield. He also had a 13 draft minimum. And that was a rule that we had so that the thesis chapter would be at least good enough to start, maybe a draft. And after a few months into my PhD, I understood the need for this rule. So I would write, and Andrew would give me very detailed, very generous feedback, of course, about the content, the sentence structure, the grammar. And I was really learning by reading this feedback and absorbing all the information. But I think this one particular chapter might have nearly broken him. The comment said, "This is the most upside down, back to front, inside out sentence I have ever read. ... Fix it. 4 exclamation marks." And I was like, oh dear, it must be bad. Yeah, okay. And so then in our meeting, he's like, are you English as a second language? And actually, technically I am, but actually I did all my schooling here, so there's no excuse. I'm just a terrible writer. And he said, I think, you got apples and oranges and you're trying to put it all together. We need to work on this. And actually, with a lot of patience from Andrew and constant support, which still continues today, I can confidently say I think my writing's gone a little bit better. Now, as a mid-career researcher, the guidance has turned more strategic. What to say yes to, what to say no to, who to work with, who not to work with. And although he provides very pragmatic and intelligent overview, the advice often finishes with, but don't listen to me. I'm terrible at saying no. I have no boundaries and I can always overcommit. Okay. You probably know that until very recently, he had quite a heavy clinical load in the consulting rooms as well as in the prisons. Actually, he saw a patient yesterday, which I didn't realise. And I think he's the definition of a truly caring clinician researcher. So at the fatigue clinic, we would often get referrals from well-respected specialists with a respectable referral letter about half a page to a page each. And then we get Professor Lloyd's referral letters. Minimum 3 pages, up to 6. And I think that just showed us how good of a doctor he is, where he looked at the person as a whole rather than just their illness. And guaranteed every patient that came to see us that would see Andrew would come in and they'd say, oh, we just love Andrew Lloyd. He's just so understanding and finally have some answers. And we say, yeah, we love him too. And I think his compassionate approach to patients was instilled to us at the fatigue clinic, where I think we've trained to be good researchers, good clinician researchers and clinicians, where we look at the evidence base, but we treat the person that's in front of us to help them tame the beast that is the fatigue. I think it's really few people who get to the level of esteem of Andrew and continue to be so engaged and present and available to their mentees. I mean, how many professors do you know who actually still screen thousands of titles and abstracts for systematic reviews? I feel that Andrew always goes above and beyond, which in turn makes us do the same. And I think that's what sometimes makes the tough world of academia worth doing, working with good people who are creative and that make you better. Someone once told me that your supervisor and your mentor should not be the same person. Your supervisor really has an interest of the task at hand to make sure that you do something. And your mentor is meant to look at you kind of big picture and your whole career. Of course, I actually agree with that. But I feel like with Andrew, that's not been a distinction, because I always feel like he's got our back. And oh my God, it's not like an obituary, like you said. Terrible. Yeah, I just feel like Andrew's always had our back and has got our best interests at heart. And thank you for everything, Andrew. And I know you'll be embarrassed probably by the fact that I'm crying and also about all the nice things that people have said about you. But I think, like you'd say to me, it's good for you. So it's okay. Thank you.
Oh dear, okay. I'm going to try my hardest to also not turn into a bit of a blubbering mess. And I'm going to say a few more nice words about Andrew, which he is going to hate. So for those who don't know me, I'm Yumi Sheehan. I'm often known as the prison's Hep C girl, and this is a title I wear with great pride. Now, with a degree in linguistics and psychology and a background in cognitive science research, specifically working on reading and spelling difficulties in children, you might be wondering, how on earth did I end up working with Andrew Lloyd in the prisons and Hep C space? The complete opposite end of the spectrum. And it is a fair question, and it's one that I often get asked. And I still remember in my interview for the study coordinator role with Andrew at the KIrby back in 2018, the job description clearly called for somebody with a degree in biomedicine, or at least something very sciencey. which I very much did not have. But there I was across from Andrew, and he asked, so why the prisons? Why this job? And I said, honestly, it fascinates me. I know nothing about it, but I'm here for it, and I'm ready for the challenge. And somehow that was enough. Andrew took a chance and hired the girl from linguistics. And little did I know that I had landed not only a job, oh dear, here I go, not only a job, but a career and a mentor with a truly exceptional human being. For the past 7 years, I have had the absolute privilege of being Andrew's 2IC in the prisons and Hep C space. Together, we've led Pivot, we've led HepEd, OzHep, the national and international prisons hepatitis networks. We've developed national and clinical guidelines. We've undertaken advocacy, and we've both learned together about modelling and health economics. We've hosted workshops across Australia and across the globe. We've built incredible collaborations. We've shared countless laughs and far too many lollies. Somewhere along the way, Andrew also convinced me to do a PhD. And his pitch, well, you're going to do the work anyway, so you may as well enroll in a PhD. Classic Andrew. Practical, direct, overly ambitious, and absolutely right. It's practically become workplace legend. If you work with Andrew, there's a high chance that you're going to end up doing a PhD. And I think many of us in this room have fallen into that trap, and we couldn't be more grateful for it. Now, there's something that not many people know. Andrew and I actually share an office. Yes, Professor Andrew Lloyd is my office buddy. So every morning begins in the same way. Good morning, Andrew. Good morning, Yumi. How's it going? Fair to muddlin'. Arguably the most iconic of all Andrewisms, and one I fully plan to inherit upon his retirement. So from our office, you'll often hear the familiar refrain, "Hey, Andrew," to which he responds, "Hey, Yumi," or vice versa. And this might lead to a deep academic brainstorm, problem solving about yet another hurdle that's come our way, or to gawk at the palm trees that are flying 20 meters up in the air at the construction site next door. You never really know. It could go any way. Sharing an office with Andrew, though, has meant I have had a front row seat to his generosity, his calm wisdom, and incredible availability. And we've all spoken about this today. No matter how busy he is, he always makes time for his staff, for students, or for anyone that needs support. We've even developed our own Zoom dynamic, often joining meetings side by side, one screen, two kind of bubbling heads, Andrew and Yumi, the dream team. He's been my sounding board, my fiercest advocate, and the steady compass I've relied on, just as so many others have. He's always encouraged me to speak up, to share my opinions, to be excellent, to lead with confidence, and to not concede to unnecessary bureaucracy or processes. People often ask me what it's like to work with Andrew. I always say, how many professors do you know who not only share an office with a junior academic, but also treat their opinion as equally valid from day one? I've tried my best to emulate Andrew's style of leadership and mentorship, but I have a long way to go. Andrew is the kind of mentor who gently nudges you off a cliff, not out of carelessness, but because he knows that you can fly. Even when you're flapping around like a headless chook, especially at the tail end of a PhD, he'll just smile and calmly say, "It'll all be sweet." And it always is, indeed, all sweet. He's taught me to think critically, to stay curious, and accept imperfection. He's reminded me again and again that life's a compromise, especially in academia. And he's almost succeeded in stamping out the perfectionist in me. That shift has changed not only how I work, but also how I live my life. Andrew often says, if you can do research in the prisons, you can do anything. And honestly, he's right. The red tape, the ethics, the governance, the logistics, it's a wild bureaucratic roller coaster. Often everything is clear as mud, but somehow we've stayed sane and we've kept pushing boundaries. Now, Andrew is an incredibly accomplished person, as we've heard today, but you'd never know it from him. That's why we're here today, to sing his praises, because he'd never sing them for himself. Humble to a fault, he's passed on more than just a single legacy, with so many of us stepping into the pillars of work he managed on his own, and that's nothing short of remarkable. Excuse me. But beyond the publications, the grants, and the accolades, it's the mentorship and care that Andrew has shown that I think has left the deepest impact on all of us. Not only has Andrew shaped our careers into what they are today, but he has supported so many of us through the trials and tribulations that life throws our way, with unwavering kindness, patience, and humanity. He sees the person behind the professional, and that's something I know we will all carry with us. Andrew, here we are, the moment you've been mentioning since I first arrived. It's finally almost here. It has been the greatest honour to have learned from you and to carry your work forward with the rest of the prisons team. Thank you for bringing me along on the prisons Hep C journey. Even though you're not quite completely leaving us just yet, and how lucky we are to have you for a little bit longer, I promise to keep waving the flag for the prison sector into the future with the same passion, integrity, and commitment that you've shown and instilled in all of us. Thank you for your academic brilliance, your sharp wit, your calm steadiness, and your deep, unwavering care. You haven't just shaped my career, you've helped shape me, and I know so many in the room feel the same way. I will forever be grateful that you took a chance on hiring the girl from linguistics. Wishing you all the joy, rest, woodworking, grandkid time, and adventures with Andrea that retirement can possibly hold. You've left an enormous mark on all of us, and you will be deeply missed. Thank you, Andrew. What a ride it's been.
So Andrea Lloyd is now going to come up and share her reflections. Thanks, Andrea.
Well, good afternoon, everyone. I want to share a side of Andrew that many of you, his colleagues, students, and collaborators might not know. You've seen the infectious diseases physician, the scientist, the clinician, but at home, we've had front row seats to the man behind the microscope. Andrew is unique in the way he has blended medicine, science, family, and fun. He continues to shape my life and our children's lives, their partners and our grandchildren with love, empathy, generosity, and a measured, practical approach to every situation. You can't catch cold from being cold. This is Andrew's way of saying evidence matters. While other kids were being zipped into jackets at the first sign of a breeze, our children were the ones in T-shirts in July because Andrew reminded us viruses don't care about the weather. He taught us to question things, to look for data, and to never accept "because I said so" as an answer. It wasn't just about science, it was about how to think. And while it didn't always win popularity points in the kids' schoolyard, it gave me and our family a lifelong respect for truth, honesty, logic, and the occasional controlled experiment in the backyard. It'll only take a week. This is Andrew's rallying cry for every DIY project that spiraled into a family saga. Whether it was building a pond, a natural swimming pool, an authentic billy cart, a tree house, or renovating half the house, Andrew's approach is with optimism, research, a sketch pad, and a very loose sense of time. But more than projects themselves, it was the way he includes us all in every project, teaching the children how to use tools, solve problems, and believe that they could figure things out themselves. He was the original YouTube tutorial, except with more sawdust and fewer disclaimers. Tell me about it in a week. This is Andrew's prescription for 90% of any ailment that any of us would mention to him. Stubbed toe, tell me in a week. Mysterious rash, tell me in a week. Existential crisis, you guessed it. But behind the calm exterior was someone who always showed up when it mattered, like when Rebecca had her snowboarding accident in Threadbow, or when Simon called from overseas with a fever and a rash and a vague sense of doom, or when Eva needed help in Cambodia and David's foot grew monstrous from embedded sea urchin spikes. He might have said, "Tell me in a week," but he was always there in a moment. As time passed and grandchildren were being born, Andrew continues to generously provide an infant, childhood, adult, health hotline surface. The devil's in the detail. This saying captures Andrew's work ethic perfectly. He sets a high standard for himself and for those around him by paying close attention to every component of a task, no matter how small. It's this care and precision that defines him and that inspires myself and our family. Andrew has always given 100% to me and to our family while managing an enormous and varied workload throughout his career. I consider myself the luckiest person in the world to have fallen in love with him 51 years ago. Together, we've had incredible opportunities to live in different countries, to experience new cultures, and to learn the true value of loyalty, kindness, hard work, and perseverance. Thank you, Andrew, for the science, the sawdust, and the steady hand. You've taught our family how to think critically, build thoughtfully, breathe calmly through chaos, and you've supported me in my nursing career and in every one of my passions. Congratulations. I love you deeply and excited to begin this next chapter of our lives together.
So I believe we now have some presents to present.
We sent out a card. We sent out a card online with the apple and the coffee for those that know that. That's all. And but they had an apple out. Back to round days. Apparently, we needed our time for anything else. But people have been very generous, signing the card and giving some donations as well during retirement. We were overwhelmed with the reality.
Thank you. So we have given you, thank you, a hibiscus flower, which is going to be delivered to your house to keep you, sorry, not a hibiscus, camellia.
Camellia, it's a camellia tree.
Yes, to remember us by forever. So it's up from everyone. This is not just us. Some gift vouchers for Red Balloon, so Andrea can take you away and keep you busy doing some activities. And we've also, given the imprint you've had on our lives, we've designed a special wood brand that has the handcrafted by Andrew R. Lloyd. So when you're doing your cubby house or your homemade timber, you can really leave your stamp. So great-great-grandchildren. Yeah. Yes, you can say this is my great-great-grandchildren go, this was made by my, grandfather. So yeah, so that's from everybody.
Yes.
So thank you very much.
So I'd just like to thank all our speakers. So Nico, Carolina, Rowena, Yumi, and Andrea. I'd like to thank the comms people who helped us put this together, particularly Lucy, Elaine, and Sam. I think we've heard a lot of great things about Andrew and his extraordinary career. I think, Andrew's made extraordinary contributions over many years across a spectrum of science. And he's done that in a very thoughtful manner. And I think anyone that's been in a meeting with Andrew knows that he really drives an agenda. He is very thoughtful about the way he approaches things and very determined and driven to get things done and achieve what he set out to do, and we'll get there one way or the other. And so I think that's a great example for us all. And I think all the accolades that you've heard from the people that he's mentored, I'd just like to reinforce. And I think, the transition from his leadership to other leadership at the KIrby is assured because of that extraordinary mentorship. So Andrew, thank you for all your contributions. Go well and good luck.